Okay, first of all, I'd like to thank the organisers for inviting me to give this talk. It is an interesting area and one which we're really very much in the initial stages of, but hopefully this will provide some examples and some knowledge around the impact of COVID-19 on older persons. So I'm a consultant in old age psychiatry in St. John of God's, and I've been here for the last 8 years. Prior to that, I was maybe 12 or 13 years a consultant in the HSE, again in old age psychiatry. So there's no doubt that 2020 has been a very difficult year worldwide. There has been an impact on all sections and ages of the population. For example, homeless people, travellers, school-going children, leaving cert class, university students, working age, adults, healthcare workers, and older people. Really, there's an impact on everybody in the population. There are certainly different stresses and impacts on differing countries around the world, between Europe, Australia, United States, and so on. I was delighted to see that Australia has eliminated the virus in the last week or so, and hopefully that will continue, and hopefully our current lockdown will have a positive impact on the rate of the virus infection in this country. And while we can learn many lessons worldwide, we also need to apply these to our own country and population, as everyone is different. Since March 2020 in St. John of God's, we have seen an increase in referrals and admissions in my department and for older people. And not only has occupancy increased, but also the type of, there have been changes in the types of presentation. So for example, we would normally have many more older women admitted than men, and equally to the outpatient clinic. Now we are seeing many more men. And we're also seeing more people with, who have no previous psychiatric history presenting with very significant illness. We're not talking about minor anxiety or health anxiety, but rather major depressive episodes with or without psychotic features, with suicidal ideation or indeed suicide attempts, and some with psychosis. We've also had people with dementia who have deteriorated as a result of the pandemic or the lockdown. So what I wanted to talk about was a number of areas, particularly the impact of the pandemic and on older people, and the impact of social restrictions or lockdown on older people. There's also the impact of the illness itself, and I'm not going to talk so much about that because that then we are looking at neuropsychiatric sequelae. I will talk a little bit about that at the end. I'll talk about some of the clinical presentations that we've seen, and also looking at reducing the adverse psychological impact of quarantine. I think it's really important that we look at how we manage that as well. There are certainly challenges for the delivery of mental health services for older people going forward, and certainly there are research opportunities in this area. So we know that with previous pandemics and large-scale disasters, whether they be traumatic, such as the World Trade Center, the natural disasters such as hurricanes or earthquakes or environmental disasters, there's an increased risk of depression, increased rates of depression, PTSD, adjustment disorders, and substance misuse. Certainly during the SARS epidemic, there was an increased rate of PTSD and psychological stress. Research has shown that there are increased rates of suicide in the USA during the 1918-1919 influenza pandemic, and during the 2003 SARS epidemic, there were increased rates of suicide amongst older people. For the COVID-19 pandemic, well, we're all aware of this data now. The first cases were reported in Wuhan in China in December 2019. After that, there was a rapid spread of the coronavirus right throughout the world. And on the 11th of the 3rd, 2020, WHO declared it as a pandemic. We locked down for the first time on the 27th of the 3rd, 2020, and we're now a couple of weeks into another national lockdown. hope we are reducing the viral infection rates, but unfortunately, the numbers in the older people are now rising, and I see that the Chief Medical Officer only yesterday has expressed his concern about that. So with looking at the numbers from May 2020, of particular note are that 90% of those who died were over the age of 65. The median age of those who died was 83, and the median age of all cases was 48. So clearly there is an increased risk of mortality in the older age group because of their vulnerabilities and comorbidities. I've noted that there's a recent paper from South Korea, which actually shows there's an increased risk of mortality in older people who have mental health disorder, which seems to be a risk factor in itself. Perhaps because they have a higher rate of comorbidities, it's not clear as yet. So as I said, we're focusing on mental health, really on the effects of the pandemic and the effects of quarantine or lockdown. And I will talk a little bit about the neuropsychiatry sequelae of COVID-19. So why are older people vulnerable? Well, they're vulnerable because of their associated comorbidities, hypertension, diabetes mellitus, heart failure, COPD. They have a less effective immune system, so they're more likely to get COVID. There's a potential limited access to healthcare. Now, primary care is often by telephone, so this may not suit older people. There may be hearing difficulties, and so there's a potential for limited access. Social isolation, as we know, is a risk factor for depression, and with a pandemic raging in the environment, then there's increased risk of social isolation before we get to quarantine or indeed lockdown. I think one of the other issues is that in the media, certainly in the initial stages of the pandemic, every time you turned on the radio or the television, it talked about the vulnerabilities of older people and how they were more likely to die. And I know from talking to my patients that a lot of them suffered huge anxiety around that initial period because of that. Social distancing and quarantine causes social isolation, as I've mentioned, a risk factor for depression. There's a lack of contact with family and friends, and I speak with my patients, and very regularly they tell me about how they haven't been able to see their family, they haven't been able to hug their grandchildren. Sometimes they haven't even met their grandchildren. Babies have been born abroad and they haven't been able to visit abroad, or their family haven't been able to come back to Ireland. There's a lack of access to daycare centres, community centres, the churches are now closed. All of these places would have provided a social connectedness for older people, and this is a major difficulty for them now. Golf is closed now during the current lockdown. Again, a lot of older people used it as a social connection and find it difficult to understand why it's not allowed during this particular lockdown. The restrictions to visiting to nursing homes, I think, are particularly difficult. And I know this both from professional and personal experience. An extended member of my own family was in a nursing home and didn't have any visitors from her family for 5 months, which is very difficult for the individual concerned and also for the extended family. Window visits are being offered in some places, and in some places are not being offered. So there's a huge risk of isolation and also deteriorating cognition in people in nursing homes without the stimulation that their families can provide. I've mentioned here, again, the increased risk of depression, increased risk of cognitive decline, and certainly there's an increased risk of or increased rate of PTSD in those with dementia. There have been, as we're aware, excessive deaths in older people in residential care, and this is something that will be looked at later, I'm sure. But one would wonder about how our nursing homes, in terms of the environmental issues, and how they can be more protected from this virus. Certainly, there's a higher risk of outbreaks in that setting. So, with regard to mental disorders, An early study carried out showed a prevalence of depression and anxiety of 37.1%. There's a higher risk in those who have had previous mental health disorders. There's an increased risk of psychosis, which has been shown in a number of papers. And with regard to dementia, there is an increased risk of cognitive decline and BPSD. I've listed some of the research that has been carried out to date. It's limited because we're very early in the time of the pandemic, and it's very hard to tell pre-COVID rates versus current rates. However, the first article there is about the increased rates of depression and anxiety during COVID-19 restrictions in older people with Alzheimer's dementia in retirement homes in France. Certainly, an overexposure to COVID-19 related news is associated with a higher level of depression, and I've already mentioned isolation. Positive coping strategies lead to lower rates of depression, and also there's an increased higher levels of anxiety. There's been one Irish study carried out during the first week of lockdown, which shows significantly higher levels of COVID-19 related anxiety in people over the age of 65. It was just carried out in the first week, so it would be interesting to repeat that again. When it comes to dementia and PTSD, there's an increasing irritability, agitation, and anxiety, a worsening of anxiety and depression in AD, and a worsening of hallucinations in DLB. There's also the increased stress-related symptoms in caregivers because their nearest and dearest, the people with dementia, have no longer anywhere to go during the day. There's no day centre, there's no respite, so that can cause difficulties for them. Disturbingly, there's an increased use of psychotropic medication for those with dementia, with all the adverse effects that this can have, and that is of concern. The survey from the Alzheimer's Society in UK looked at 2,000 people affected by dementia, and they found about a third had a sense of apathy or giving up. Clearly, this is of concern, and they also looked at the rates of the death rate and suggested that there was a higher rate of death because of this apathy or sense of giving up because of the restrictions and the lack of visiting. I spoke a little at the beginning about reducing the adverse impact of restrictions. I think it's important, first of all, that the government put out clear communication as to what the pandemic entails, how the virus affects people, why there needs to be restrictions so that people are aware of it. I think some of the problems we had over the summer were that the people were not aware or understanding of what needed to happen in the future. Very important for people to stay connected by whatever means that may be, and it may be through digital technology. And we need to set limits to news and social media because use of that can lead to further depression and anxiety. Support and routine, moving and exercise, these are all helpful in reducing the adverse impact. We know that time spent, and it has been shown in research on work, housework, gardening, exercise, etc., all can be associated with improvements in mental health and well-being. Mental Health UK suggested psychological first aid, which really is to provide support and connectedness and access to services. It's very simple, but it is a way of helping people to cope with the difficulties that they have. Two research studies here show that outdoor activities such as gardening and exercise lead to increased mental health and well-being, and an increased time following news about COVID-19 predicted declines in mental health and well-being. I'm certainly aware myself that you can get very sucked into looking at the figures every day, and then not only the figures in this country, you can look at the figures around the world, and it can become a focus and can become stressful and depressing. Looking at the challenges for the provision of services in the future. First of all, I think there needs to be an implementation of parity of esteem for those with mental illness and physical illness. The College of Psychiatrists of Ireland has been promoting this for quite some time, as indeed have the Royal College of Psychiatrists. And I think it's very important. We need to have a mental health monitoring system that includes outcomes related to mental health service use. And these measurement of outcomes should include both service users and their families. We need to prioritize existing services and promote new practices that expand cost-effective delivery of effective mental health services, which should be of high quality of care, and they should be accessible. I have primary care support in. It really should have been at the top, because clearly that's the first port of call. It is very valuable for people to access mental health services, and maybe they don't need to be referred after they've been to primary care. So that's also very important. I'm interested that the Mental Health Commission have looked at some of the inpatient facilities and have said that they are not fit for purpose during a pandemic, and these are other areas that need to be looked at. We need to use digital technology where we can. Unfortunately, or certainly some of my patients would not be able to manage video conferencing or remote video consultations, but they can manage phone consultations. When you're familiar with the patient, this can work very well. There's a couple of hospitals in the city now looking at inpatient at home initiative. It'd be interesting to see how that works out. And there are a couple of research projects going on in the northwest of the country using technology to support people either with dementia or with other forms of mental illness. I said I'd mention neuropsychiatric complications and to outline what complications that can arise. Delirium is the most common. We know that during SARS and MERS it was 27.9%. The adverse effects of medication, steroids, can cause mania and psychosis. Certainly people who have had a serious illness are much more prone to depression, fatigue, anxiety, PTSD. COVID-19 can cause a hyperinflammatory state, and the link between inflammation and depression is well described and will be something that will need to be looked at in the future. There was one study of severe cases which reported that 1/3 had a dysexecutive syndrome, inattention, disorientation, or poorly organized movements in response to command. It's not absolutely clear what the cause was and how long lasting it was. So this is something that will have to be studied in the future. Future studies, really we should be looking at the prevalence of psychiatric symptoms in those with infection. We should try to do prospective studies so we can see the effects of the pandemic and the infection on older people. We should look at markers of severity of infection and perhaps correlating that with psychiatric symptoms. The long-term relationship between infection and post-infective fatigue or depressive symptoms would be an interesting area to look at, as would biomarkers of CNS infection using MRI brain, for example. We also need to look at the impact of the pandemic, look at the service use, types of presentations, and use qualitative research to try and outline what we can do to reduce the burden on mental health of older people. Lastly, which I haven't listed, I do think it's worth looking at nursing homes. I wonder about how we're looking after the older generation in nursing homes, where there's such an increased risk of such infections, and how we can reduce that, and whether there are other ways to provide long-term care for our older generation. I think I'll finish it there and say thank you very much indeed, and hope the rest of the day goes well. Thank you.